So a very good evening to everyone from Singapore. I'd like to thank the organizers for the invitation to give this talk at the Women's Cancer Initiative Spine SBRT workshop. It's a real honor to be on the same stage as Professor Arjun Sagal and Professor Naresh, who are both friends and mentors to me, especially in the field of spine oncology. And the topic that has been given to me today is navigating the challenges in post-op spine SBRT. These are the objectives I hope to cover in the next half an hour or so. To look at the indications for post-op spine SBRT, to look at the imaging modalities used, as well as the patterns of failure, to cover the CTP and OER contouring, and to review some real-life cases. Setting the stage, I think we all agree that spinal metastasis causes pain and neural compromise in our patients. The indications for surgery have been covered extensively by Professor Naresh, but in summary, patients with high-grade epidural spinal cord compression, symptomatic pathological fractures, and mechanical instability do require upfront surgical intervention. And the goals of surgery would be to circumferentially decompress the spinal cord, as well as stabilize the vertebral column. And this can be achieved through an open approach or preferably through a minimally invasive approach. Post-surgery, we all are familiar with conventional axial beam radiotherapy because this is simple, cheap, and widely available. This is typically given as a 20 gray in 5 fractions or 30 gray in 10 fractions. And this is usually started about 3 to 4 weeks post-surgery after ensuring adequate wound healing. But all of this actually leads to significant downtime for the patient. And invariably, because of the way the beams come in, the surgical scar does receive about 100 to 120% of the dose because of the heavily weighted posterior field. Adding an anterior field may improve the coverage of the vertebral column, but the anterior structures such as the heart and the intestines do get about 50 to 80% of the dose, leading to increased side effects for the patients. Conventional teaching also dictates that we need to give a 1 to 2 millimeter vertebral segment margin above and below the index lesion. And this actually leads to a relatively large treatment field, even with a single level vertebral met involvement. There have not been many studies looking at the imaging-based local control for patients, but there's actually a wide range of local control from as low as 4% to around 70 to 80%. But one of the more recent studies by Epstein did report that the in-field recurrence rates after conventional external beam radiotherapy can be as high as 70%, and this can actually lead to significant morbidity for the patients. SBRT, what we've been talking about for the last 2 days, is a paradigm shift. It's applying a locally radical treatment to a metastatic patient in order to improve outcomes in terms of tumor control and also to facilitate less radical surgery for the patient. This is a value proposition because it's delivered in a short time. High dose is given in a short time. It's given under image guidance. It's highly conformal. Therefore, the radiation dose goes exactly where it needs to be and avoids the giving a high dose to the surrounding organs. And this overall leads to better tumor control and less side effects. And comparing the BED, we do know that giving SBRT, it's roughly about twice as much as radiation as giving as a conventional 20 in 5 regimen. There are many technologies available to enable SBRT, as you can see in this photograph. This is me during my fellowship in Canada with the CyberKnife machine. And basically, post-op spine SBRT, like I mentioned, does lead to improved local control rates ranging from 70 to 100%. This is very nicely summarized by Kristen Redman and colleagues, showing that the 1 year local control rates and the crude local control rates range from about 70 to 100%, with the majority being about 90%. And most of the patients also achieved a good level of pain control in the time of follow-up. Looking closer at some of the studies, so this is a single institution retrospective study looking at 186 patients who underwent surgical decompression and instrumentation. This was followed on by either a single fraction radiosurgery or a hypofractionated SBRT treatment to the spine. And what they found was that the local progression rates was pretty impressive at about 16%. And actually, there was no difference between radiation sensitive versus radio-resistant tumors. So this is actually a paradigm shift where a higher dose leads to good tumor control, even in radio-resistant tumors. What they did find was patients who were in the lower dose arm actually had higher local failures compared to patients who were receiving single fraction or three fraction hypofractionated regimen. So the take-home message is that the dose prescribed and the dose coverage are important for local control. This is a recently published phase 2 prospective study from Johns Hopkins, where they looked at 35 patients, majority of them having a single level involvement, and about 1/3 of them having a radio-resistant disease. All patients underwent surgical decompression, followed by a post-op SBRT, 30 grade in 5 fractions, where they required a minimum dose coverage of D90%, D90 more than 90%, and all patients underwent imaging and clinical follow-up every 3 months. What they found was, as we had expected, the local control rates of at 1 year were about 90%. Only 3 patients that recurred, and all of this happened at a median time of 3.5 months. All of these recurrences happened in the epidural space, and surprisingly, all of these recurrences were actually in the radiosensitive group. We were also happy to see that there was no wound dehiscence, no hardware failure, and no myelopathy in these patients. What this graph illustrates is that the graph in black is the high-grade epidural disease. So as we can see, with surgery, there was downgrading. But even with this amount of about 1/4 of patients who had residual high-grade epidural disease, there was further downsizing of this disease post-SBRT. So there was good tumor control and shrinking of the tumor with the good decompression of the spine, which happened post-SBRT. This is a study from Sunnybrook, which I just wanted to illustrate that patients who underwent suboptimal debulking or circumferential decompression. So those patients with residual high-grade epidural disease did have higher local failures, as you can see in the curve in red, compared to those patients with no disease or low-grade disease, as you can see in the curve in green and blue. So we actually wrote a commentary in the same issue of the journal. And as SBRT practitioners, we almost always prioritize the organs at risk over target volume coverage. So therefore, if there's high-grade residual disease, some part of this disease will be underdosed, and this will invariably lead to epidural recurrences. We also put forth the point that for any center performing, spine SBRT, a dedicated spine oncology team is required, where there's good communication between the spine surgeon and the radiation oncologist, for them to work closely in order to optimize patients' outcomes. Looking at the indications and contraindications for SBRT, the clear indications would be those with radio-resistant disease, where we think conventional radiotherapy will not work as well, patients requiring re-radiotherapy, or patients with oligometastatic disease, where you want a good control for the duration of their survival. And contraindications can be absolute or relative. So this is rather relative, up to 3 vertebral segments. But clearly, patients with Asia grade A, such as complete motor sensory loss, or patients with residual high-grade disease, perhaps should not undergo post-op SBRT. So this is a flowchart Professor Naresh and I came up with in order to sort of streamline the treatment for patients with spinal mets, in order to decide who requires surgery and what kind of radiotherapy is required post-surgery. But in my very simplistic mind, I'm quite binary. I like to just look at a few factors when I look at see a patient with spine mets. I want to ask myself, what is the patient's performance status? What is the extent of systemic disease? What is the severity of neural compromise? And is there any issues with spine stability? And based on this, we will decide whether the patients require surgery and how aggressive we need to be with the radiation post-surgery. And now that you've decided that you want to give SBRT, the next question is when to do it. So this is a systematic review that Prof. Naresh and I worked on. So this primarily looked at conventional external beam radiotherapy, where we summarized that ideally the time between surgery and radiotherapy should be at least 2 weeks, with a minimum of 1 week. At our center, at least for SBRT, we wait about 2 to 3 weeks post-SBRT to initiate the treatment, whereas for conventional radiotherapy, we wait about 3 to 4 weeks. And this is primarily because we can control the dose, the surgical corridor and surgical scar with SBRT better than what we can do with conventional radiotherapy. And with the longer interval, clearly the wound healing would be better. However, we are taking the risk of the residual disease progressing in this time period. And actually, we're also delaying the time that the patients can reinitiate systemic therapy. So often the medical oncologists do not restart the chemotherapy until the RT is usually over. And there's a risk that the extra spinal disease can progress during this period if this period is going to be too long. Coming to the crux of the talk, looking at the challenges in post-op spine SBRT, I have mainly selected three main factors to touch on, basically imaging, target delineation, and dosimetric uncertainties. So let's look at imaging first. So clearly, we are all well aware that both CT and MRI play a complementary role for patients undergoing post-op spine SBRT. CT is required for dosimetry. We can't do without it. And actually on CT, on the bone window on the CT, we can actually see the instruments pretty clearly without much distortion. But the downside is that, we do have quite a bit of artifacts as we see with titanium implants. As we can see here, we see holes here as well as streaking artifacts, surrounding the implant. MRI images are good for soft tissue and paraspinal tumor delineation, as well as looking at the spinal cord itself. It's also quite sensitive to detect marrow infiltration. The downsides of MRI is one, definitely cost will be more than CT. And the time required to do an MRI is definitely longer. And when patients are in pain, it can be quite a challenge in some settings. Additionally, the metal implants do cause susceptibility artifacts and distortion. And therefore, there can be some spatial distortion that can happen because of the metal artifacts. So the NCIS MRI protocol is very similar to Sunnybrook. I know this is modeled after Sunnybrook based on Professor Sagal's publications and his guidance. So we actually do a volumetric thin slice T1 weighted imaging with and without contrast, gadolinium contrast, as well as a T2 weighted imaging. And the advantage of this volumetric acquisition is that we can actually have a multi-planar reconstruction while maintaining the image quality. And we don't do a whole spine imaging. We're quite targeted in the regions that we image. This actually reduces the cost for the patient as well as the scan time. And we usually can obtain the scan in about 20 to 30 minutes. This is just an example of a patient with who underwent post-op spine imaging. We can see the T2 imaging, T1 with contrast and stir imaging. So the main challenge in imaging is that it can be relatively tough to differentiate post-op changes and blood products from residual tumor. Some of the tricks that our radiologist uses is to look at the size reduction, signal changes, as well as contrast enhancement. Sometimes we have to rely on advanced modalities such as DWI, or if we're not sure, we may have to do interval imaging to actually ascertain this. For MRI, certain vendors have come up with certain protocols which can actually suppress the metal artifacts. But other things that can be done is using a lower strength magnet, such as a 1.5 Tesla, using a spin echo instead of a gradient echo, and increasing bandwidth and matrix. But definitely, we just got to involve our neuroradiologists when coming up with these protocols. Looking at CT scans, similarly, vendors have come up with certain protocols and sequences we can suppress the metal artifacts, such as OMAR. And more recently, dual energy CT has been shown to reduce the metal artifacts that can be seen with as we do with the usual single energy CT scans. If all else fails, CT myelogram is actually quite a good way to delineate the spinal cord, but this is slightly more invasive compared to a normal MRI scan because this involves injecting the contrast into the thecal sac. So this is from our paper, basically just showing that with metal artifact reduction sequences, both the MRI images and CT images can be improved, in order to delineate the vertebral column as well as the soft tissues. Next, we'll go on to target delineation. So before we talk about target delineation, let's look at the patterns of recurrence. So this is a paper from Sunnybrook once again, and they actually, they had two types of targets: a donut type target where everything is included except the spinal cord, or a horseshoe type target where the posterior segment, the spinous process area, can be spared. And in order to determine which type of target can be used for which patient, let's look at the data from their institute. What they found was if the preoperative extent only involved the anterior compartment, none of the patients failed in the posterior sector. So this is considered a safe zone if there was no involvement of the posterior sector up front. Whereas patients with involvement in both the anterior and posterior compartments, they were at risk at failing all round, and they warranted a donut type target. Another phase 1-2 trial also suggested that the predominant patterns of failure in post-op spine SBRT was 1, epidural, and 2nd, paraspinal. So these are the areas that we got to look at closely. So this consensus guidelines was published about 4 years ago. And they have done a very thorough explanation of how these CTV should be defined. And for anyone doing post-op spine SBRT, I urge them to be familiar with how these sectors are defined. And if I can summarize the paper, I think, just basically, I just want to say the residual GTV must be covered adequately, and there should be some margin given to paraspinal and epidural disease. Second, the CTV should include the preoperative extent of the bony disease, epidural disease, and also the immediately adjacent compartment in order to tackle any microscopic disease which may be lurking behind. Generally, the surgical hardware can be spared because they are usually not placed in an area where there's tumor. And for PTV, most institutions use about a 2 to 3 millimeter PTV, but generally the PTV is cropped at the neural structures, such as the spinal cord or the plexus. Yeah, so this is the paper showing the 10 different cases and how the CTV is defined. I will not go through this, but interested readers can look up this reference. In terms of defining the spinal cord, so the T2 sequence is the most important, and we can in this picture see the spinal cord relatively clearly, but there are some artifacts and distortion from the nearby rods, which causes constriction of the cord. So in cases where there's too much distortion or too much obstruction of the cord itself, a CT myelogram is required to clearly define the cord, because this is our priority for our RT planning. And also we need to give a bit of margin to the cord to create a PRV cord. And this typically is about 1.5 to 2 millimeters in order to account for any patient setup movements, as well as intrinsic motion of the spinal cord because of CSF pulsations. Next, let's look at dosimetric uncertainties. So without a spinal implant, we can see the isodose curve is very uniform. But once you introduce a spinal implant, a metal implant at least, so there is some shielding that happens, just distal to the implant. And this was very elegantly illustrated by Wang et al. Using small field dosimetry, they showed that there was a 6% increase in soft tissue dose at the soft tissue metal interface because of backscatter. But also distal to the spinal implant, there was some shielding that happened, so there was a bit of reduction of dose. But the very astute observer would be saying that we don't use a single field. So what is the impact of multi-field treatments, or what is the impact of implants on on multi-field treatments such as SBRT? And this has been studied in this paper. It's a multi-institutional paper which used end-to-end testing using a spine phantom with a metal insert. What they found was, the area of the PTV, there was actually minimal differences in the measured versus the calculated doses. But looking at column B, they found that in the spinal cord, 2 out of 5 institutions, the measured dose was higher than the calculated dose, which is a cause for concern. But actually, the difference was actually just relatively small in majority of the cases. Another area that they found that the measured and calculated dose that was different was actually at the field edge, where there was a rapid change in the dose. And that's another area where there can be differences in the what we see on the planning system versus what is actually measured. But overall, all these data actually gives us assurance that post-op spine SBRT is safe, and we do not need to make any adjustments to the target volume prescription dose, as well as the organs at risk constraints. So in our paper, we also summarized the impact of metal implants on both RT planning and RT delivery in terms of IGRT. We also suggested some mitigation strategies which can be done, which can be put in place to reduce the impact of these things. Clearly, one of the things that I did not talk about much is that of using non-metallic implants, which actually has less disturbance of the RT planning and less uncertainties that can occur as a result of the implants being in the place. With metal implants, I think the main take-home point is that dosimetrists should be familiar how to deal with these. They should be familiar in order to segment these implants and artifacts out and forcing appropriate electron density to those areas to mitigate any changes in dosimetry which can happen as a result of the implants being in place. So we'll next go on to a case. So this case was actually used at our recent course, which was actually focused on post-op contouring. And we actually had over 250 participants from the region, and it was very fun and fulfilling workshop. But I just want to use this case to illustrate a few points. So this patient is a 60-year-old gentleman with oligometastatic prostate cancer. He had a high-grade epidural spinal cord compression. He underwent decompression as well as instrumentation, and he was found to have just 4 mets. So we decided to be more aggressive with his management. If you can see in the preoperative imaging, we can see there was a high-grade epidural spinal cord compression, predominantly on the right side, but there's circumferential involvement. There was involvement of a single vertebral level, but there was also dural tracking, superiorly and inferiorly, and also involvement of the neural foramina. In terms of the T1 axial contrast, we can see involvement of the vertebral body, the pedicles, transverse processes. This is actually normal paraspinal vessel, so don't be foxed by this. This is not paraspinal extension per se, but the disease is mainly confined to the vertebral body as well as the epidural area. Post-operatively, there was decompression of the spine. This is a post-op collection, but we also see residual vertebral tumor in the vertebral body. So similarly, we want to mention that the PSMA PET scan did show active disease in the vertebral body that was present post-op. So in terms of how I approach a post-op case, this is what goes through my mind. I scrutinize the preoperative CT and MRI to see which levels are affected. I see whether there was any epidural disease, and if there was it circumferential, was it tracking up and down, and was it involving the neural foramina? I also try to see whether there was paraspinal disease and if present, where it was affecting. I reviewed the surgical notes to see what type of surgery was performed and where the implants are placed. And this allows me to anticipate what the changes that I may see on the MRI scan post-op. I look at the post-op MRI and I speak to the radiologists very often. I look at the T2 axial in particular to look at the spinal cord and the T1 axial contrast to identify residual tumor. As a general rule, I always check the fusion before contouring to make sure the vertebral body, the canals, and the rods, at least at that level, are matched properly. In my mind, I did try to determine whether I need a horseshoe type target or a donut type target. And this is primarily done by looking at the preoperative imaging. I give a 3 to 5 millimeter margin for paraspinal disease and epidural disease, making sure these are covered adequately. And usually, like I mentioned, the instruments can be excluded. So from the course, the participants actually contoured for this case. Actually, there was quite a lot of agreement for the vertebral body, but in terms of the pedicles, transverse processes, not everyone agreed. There was some under contouring which happened there, and also, in the posterior, where there's post-op collection, there was quite a lot of disagreement there as well. In terms of the superior inferior extent, most of the participants did not track the epidural disease superior and inferiorly. They more or less confined themselves to that segment. So there can be some underdosing which can happen there, which can lead to recurrences in patients. So looking at the expert's contours, so the expert in this case was Professor Simon Lowe. His CTV is in pink, his OAR spinal cord is in blue. So we got to make sure that the spinal cord at least goes about 1 cm or 1 vertebral body above and below the CTV. In this case, there was no overlap between the OAR and the CTV. It was a donut-shaped target because there was circumferential involvement up front, but the post-op collection need not be included, and this allows us to reduce the dose to the scar and the spine and the surgical area, which leads to less wound dehiscence. We also make sure that whatever you contour in the MRI corresponds to the CT well. If it doesn't, go back and check your fusion. So whatever you contour in the MRI should correspond well, and that's where you know that the treatment will be delivered in an accurate manner. So yeah, CTV involving vertebral body, bilateral pedicles, transverse processes, excluding post-op collection, tracking upwards, excluding instruments. So we're running out of time. So these are the take-home messages that I wish to drive through. So I think post-op spine SBRT clearly offers a value proposition for selected patients. We all are well aware that there are unique challenges in delivering post-op SBRT. It is a complex treatment, and particularly imaging and dosimetry can be quite challenging. So the team that you work with in terms of radiation dosimetrists and physicists should be familiar in dealing with these artifacts that we see on planning CT. Clearly, more research is required. If we can have an implant that has less impact on the imaging and dosimetry, such as a non-metallic implant, this will actually make our lives a lot easier. As for now, titanium implants are still the mainstay, and therefore, having a dedicated spine oncology team consisting of a spine surgeon, spine radiologist, and radiation oncologist who talk frequently and iron out the protocols to administer these complex treatments is much required. And from the perspective of a radiation oncologist, I know we should definitely make sure that we study the case adequately before contouring to make sure the at-risk areas are covered adequately with enough radiation in order to reduce the chances of recurrence. If there is incomplete or inadequate surgery, perhaps a more fractionated approach should be adopted, or a second surgery can be considered. Okay, so with that, I'd like to end my talk. Lastly, I'd like to thank you for your attention.